Hello, everyone. Welcome to Decolonizing Global Health in the Era of COVID-19. My name is Ivy, and I'm one of the student organizers for this conference, which has been put together by students at the University of Rwanda College of Medicine and Health Sciences and the Global Health Leadership Track in Johns Hopkins University. This conference was born out of the idea that to address global health inequities, we need to challenge the legacies of colonialism and their reproduction of exploitative and paternalistic relationships between high-income and low and middle-income countries. Our current movement has also informed this conference, as our global community faces a reckoning with anti-Black racism in medicine and a pandemic that exposes flaws in health systems worldwide, while deconstructing the narrative of Western superiority in global health.
Hi everyone, my name is Didier and I present my colleagues in Rwanda who were also involved in the planning of this conference but are unable to join us today. As a conference, we define decolonization as the process of dismantling colonial structures, power dynamics, and systems of knowledge. But we recognize that various definitions and synonyms may exist. Today, we hope to gain collective understanding of decolonization from a historical approach. To apply this understanding to critically examine how global health has responded to COVID-19 pandemic, and to generate calls to action to continue pushing this movement forward. This conference will start with a Q&A session for about 90 minutes, followed by smaller workshops groups, where we discuss a particular topic in detail and develop action items. Then we are going to return to this Zoom session, where we close with an ethics talk and discussion of action items. The webinar portion of today's conference will be recorded and made available on our social media channels.
The Decolonizing Global Health movement has gained traction in recent years alongside similar movements to decolonize methods of teaching and thinking in other fields. We'd like to offer the following quote from an article entitled "Decolonization is Not a Metaphor" by Eve Tuck and K. Wayne Yang as a framework for the conference and also for the following land acknowledgement ceremony. They write, "Decolonization, which we assert is a distinct project from other civil and human rights-based social justice projects, is far too often subsumed into the directives of these projects with no regard for how decolonization wants something different than those forms of justice. When we write about decolonization, the repatriation of indigenous land and life, we are not offering it as a metaphor. It is not an approximation of other experiences of oppression." In this article, Tuck and Yang distinguish settler colonialism, in other words, the plunder of indigenous land through violence and genocide, from the byproducts and tools of colonialism, in other words, racism, sexism, capitalism, militarism, etc. They criticize use of the language of decolonization to represent justice movements that are anti-colonial in nature, but fundamentally removed from efforts to repatriate indigenous lands. We as a conference have strived to ground our content today in the history of colonization and the direct line between colonial enterprise and health inequities today. But we recognize our shortcomings in failing to center indigenous perspectives in this conversation. So a land acknowledgement ceremony is a necessary but by no means sufficient action to undo indigenous erasure and promote indigenous struggle for self-determination. Although we have gathered virtually today, we recognize that many of us currently inhabit sacred native lands. For those of us in Baltimore, Maryland, in the United States, where Johns Hopkins University is located, we live and work on the ancestral homelands of the Piscataway people. These homelands extended from the shores of the Chesapeake Bay to the watershed of the Potomac River. So today we honor the elders, past and present members and future generations of the Piscataway people, as well as members of the Appalachian tribes of the Northeastern Iroquois Confederacy and the Lumbee people from the Carolinas who migrated to Baltimore under pressure from federal assimilation programs, including the Indian Relocation Act of 1956. We acknowledge our own presence on these lands as the outcome of forced dispossession by European settlers, and we acknowledge the continued impact of violence and trauma on Native communities in the form of both environmental and health injustices, especially pronounced during this COVID-19 pandemic. Since we are limited on time, we offer these acknowledgements as only a point of departure. We also understand that attendees of this conference may call many different lands home, and each country has a different relationship with the emerging practice of land acknowledgement ceremonies. Over the next few hours and beyond this conference, we challenge attendees to interrogate their own roles as beneficiaries of a colonial system, as a community of individuals united by a common goal of dismantling colonial structures and achieving health equity. We hope to push each other to be self-critical, to ask ourselves why and how we have employed the language of decolonization for our movement, and to resist erasure of Indigenous voices in this conversation. We wanted to provide a short list of resources and ways to support organizations advocating for the rights of Indigenous groups, but recognize that a single slide cannot do justice to the richness and diversity of Indigenous histories of struggle and resistance around the world. So please feel free to take a screenshot or a picture of this slide, to send a Q&A to any of the conference organizers, or to reach out with any comments or feedback following the conference.
Hello, everyone. Before we begin, we would like to acknowledge a few additional points regarding the scope of our conference. We want to acknowledge that we respect all iterations of the decolonizing global health movement that bring us closer to a more equitable, just, and effective global health practice. We acknowledge that the topics we chose are not comprehensive, but rather we chose topics that we felt are particularly salient in this time. Our goal today is to provide a platform for individuals from around the world to collectively learn, discuss, and improve the field together. And as always, we welcome any feedback at the conclusion of the conference. Finally, we would like to give a little bit of demographic info of who we are and who registered to be here. Our goal for this conference was to bring together a group of experts, health professionals, and students from a diverse array of backgrounds, and are striving to provide a platform for all voices to share their perspectives. And we hope that today's conference, particularly the workshop component, can serve as a model for multi-sectoral and transnational partnerships. On the slides, you see the different representation we have today, and we're particularly excited that we have representation from 87 different countries of origin and 74 different countries of residence.
Hi everyone, my name is Khadija and I'll be moderating the Q&A panel with Ugo. I'll start by introducing each of the speakers on our panel, and they'll give brief summaries of their pre-recorded talk. First is Dr. Alexandre White. He is an assistant professor of sociology at Johns Hopkins University and is affiliated with the Department of the History of Medicine. His work examines the social effects of infectious epidemic outbreaks in both history and contemporary settings, as well as the global mechanisms that produce responses to outbreak. His work in fields beyond medical sociology has explored questions of racial subjectivities, anti-colonial revolution and uprising, and structures of colonial domination and resistance. I will now turn it over to Dr. White for a few words.
Hello, everyone. It's really an honor to be here, and thank you so much to the organizers for putting this together. And it's great to be in front of all these wonderful attendees. So my presentation primarily concerns the question of what does it mean to decolonize global health? Foundationally, when we think about this in the contemporary moment, we too often, I think, focus almost exclusively on the questions of who holds the purse strings and the economic power to enact policy globally around health and control the systems of global health that operate. But I want to stress, and I stress in my presentation, that when we think about decolonizing global health, we should also think about the knowledges and perspectives that global health represents. And formally, this requires a reckoning with colonial histories. While thinkers such as Edward Said and Frantz Fanon and others have shown that in order to make colonization an effective mode of domination, which of course it was an extractive process, a variety of knowledge projects have to occur to allow for extraterritorial sovereignty to work foundationally. The economic exploitation of people was also a phenomenological or ideological exercise in knowledge production. The knowledge projects were total ones, including the natural sciences and of course medicine, in which it was assumed and presented that colonized people were incapable of governing themselves, and also very importantly, incapable of setting up and creating health systems that they could thereby run that would be at the same levels as the rest of the world. And I think this is very important to think about because we're talking about agency over health. And we're talking about decolonizing the systems by which the world would assume that formerly colonized nations lack that agency and lack that capacity. So when we challenge and attempt to decolonize global health, we should also think about the knowledge projects and practices and histories of colonialism that go into the current structures of global health that we see today.
Thank you, Dr. White. Our next speaker is Loyce. She is a global health leader who has worked on the ground in more than 15 countries, delivering health programs and mobilizing advocates. She has served as the Global Health Council's president and executive director since December of 2016. She has championed policies for access to essential medicines, testified for congressional global health appropriations, and elevated the voices of people at the community level around various shared advocacy goals. We're excited to have her here with us. Ms. Pays, please say a few words to the audience.
Great, thank you, Khadija, and thank you to the co-organizers for continuing this very important conversation. I also want to offer my gratitude for all of the people who helped shape my learning and growing along my journey in this space and in public health and global health, from where I started in my hometown in an inner city here in the US, to all of the work that I have been able to do in partnership and alongside powerful people in Southeast Asia and Sub-Saharan Africa in particular. And I also want to give my regards to the two women whom I interviewed as part of my lecture, Kadi Touré, who hails from both Mali and Senegal, and she's based in Geneva currently, as well as Angela Nguku, who's based in Nairobi. Because I hope that those of you who were able to tune in for that really gathered as many insights and inspiration as I did. And so I think in summarizing that talk, I wanted to focus on a few areas. One is sort of what I continue to learn, and I think what we in the US in particular and international NGOs continue to learn as part of this process. Secondly, what we're doing about that in light of those lessons, and then finally, what comes next for us. I'd be remiss if I didn't acknowledge that this isn't necessarily a new conversation, and I think the organizers have said this themselves, either in planning or in the presentation thereof. You have a book like Dead Aid that came out over a decade ago now, which really called out the colonial practices of development broadly, including global health. And so we continue to grapple with this question. And I think that's important to consider, that there are many people before us who cycled in and out of NGOs, the UN industrial complex, and otherwise in frustration. What's different about today, though, and I think it's going to be highlighted, is the reality of something like a COVID and this truly global health emergency that's really bringing into stark relief some of these ongoing problems and practices. And so it's my hope that we can finally more directly address this problem, if not tackle it once and for all. It's still going to take time, arguably. But I think the good news is that those of us are coming together to try and do so. And in particular, those of us in these positions whereby we can affect change amongst some of the bad actors. And I hesitate to kind of offer too much judgment there. I'd like to think that everyone is doing the best that they can. And yet, I think with these larger international institutions, there's a lot more work to be done. And whereby there are groups like you all who have convened around this question in years past, that hasn't happened as readily or as frequently, I would argue, among, for example, the US global health community and all of these major organizations and institutions here in Washington, DC. So I think that's something that has changed and that is different. I think what we are starting to do now is asking, listening, and really paying attention to what we hear in response to this question, what is or isn't working and what can be done about it. I think another thing that we're doing is trying to really hold to or really practice the values, I should say, that we claim to hold, really practice what we preach. We say that we are all about justice and equity. We say that we are all about sustainability and transition and passing the baton, or putting others in the driver's seat or leadership role. And yet that's not something that we readily demonstrate. And so I think the more that we're asking the question, listening to the answer, the more we're recognizing that we need to do a lot better in terms of living and leading into our values. And it's my hope that that will also help us kind of get to the other side. I think the last thing I will offer by way of summary is sort of what's coming next. I think for those of us, again, in Washington and to some degree, folks in Geneva or New York who are kind of in the policy hubs around global health. I can speak for Global Health Council. We have been brokering this conversation around how to reshape or reframe US global health, which is really important. And there are a couple of sides to this, both the narrative, how we message the need, as well as really what we're doing and how we're approaching that. So I'm happy to get into that as part of the discussion or Q&A. But I wanted to say, even though it might not be written in BMJ or Lancet or otherwise published, the work and the hard work is underway. I think I'll go ahead and end there. And just to say as a final note, one question that I did ask as part of this lecture was whether or not the people with whom I spoke still had hope, or why they still have hope. And I thought it was really powerful for them to speak to the power of individuals, the fact that any change is driven by people power. And so at the end of the day, it's really up to each of us to drive this change. And I believe we can do it. Thank you.
Thank you so much, Ms. Faze, for those very wise words. Our final speaker is Dr. Adres Malata. She is the Vice Chancellor of Malawi University of Science and Technology and holds multiple leadership positions in nursing and international health organizations. Dr. Malata has spearheaded the development and implementation of programs in the fields of health, science, and technology, and facilitated capacity building efforts for faculty in various fields. We're all honored to have her here with us today. Dr. Malata, please say a few words to the audience.
Thank you very much, Khadija, and thank you very much to listening to the two other speakers, very inspiring to me. And I think I bring to this conversation another context, because I live and I've lived all my life in a rural resource setting country, Malawi, and have worked with colleagues in other countries within sub-Saharan Africa, but of course I've also had to take on positions on the international scene and work with colleagues from all over the world. I did serve at one point as Vice President of the International Confederation of Midwives. I think I really enjoyed even just looking through information about this conference, and I want to congratulate you, all of you, and you're young people, so I'll be talking about leadership as I conclude, but certainly I was inspired with your energy, and I want to encourage you. And the reason I say this is I've raised in one of my slides at the end of my presentation issues that I think we need to look at. If we really are going to tackle this issue and decolonize global health, I know the debate has been there for a long time. Whether we're making progress or not is another issue. But I do think that those of you who are on this conference need to start asking those uncomfortable questions. Where are we in leadership? So low and medium income countries, the question should always be, yes, we want to get there, we want to make decisions, we want to influence policy, but we are not on the table. And people are making decisions. We are not there on the table. And if we sit on that table, and I want to now specifically look to those of you who are women or girls in this conference, is if you are not on that table, people will make decisions for you. And whether it's in research, education, policy, get on that table. And I've learned over the years, having worked for 30 years and really been all over the world, I've realized if you don't get yourself on the table, then you will not get your voice heard. And when you're on that table, please choose a menu. Don't keep quiet. Because people go out to conferences, or maybe they present a paper, a few people ask questions, and that's it. No change, no influence on policy. Then moving on, I'm also saying that we really need to critique the teaching and learning. And although there's a discussion, I think every time people are saying, okay, we're going to change, our curriculum will be different. But I can assure you that teaching and learning is still the same. We're still not changing. New programs of medicine, nursing, we still don't see, that identity that this is about us, this is about our context. I'm also talking about the fact that we don't control data. Our data is used, people come in our countries, they do research. Many times that research is not going to benefit us. If it benefits us, it's very minimal. They get the data, they get the information, and they go. We are not in control. We are not principal investigators. Many times, principal investigators. Now, the moment you're not leading, then you're not in control, because somewhere, somehow, you still have to follow who is the leader. And I've also talked about issues of language. Can we go beyond English? Yes, French has been given space, and then perhaps now we have other languages. But I do think that we need to really start discussing that we need to go beyond English so that we can reach out to everyone, everywhere, and then we can say, yes, we are impacting the whole world. And of course, I do believe the power of activism. And I think the Black Lives Matter has reminded of us that, if we really get our energy together and we go into, positive activism, we can change the world. We can actually decolonize global health. And of course, I do believe that as young people, you have to learn to lobby. And then, of course, collaboration is another debate, because I do think that we don't have fair collaboration. And for you to collaborate with individuals or people, you need to have that long experience. So I get people contacting me like, we go to you, we found that you've written this, you've done that, we want to work with you on this project. But I'm saying, how am I going to help young people in those countries? They don't know anyone. But we all need to make sure that, I think as we lead, and those of us who are in leadership position should really make, create opportunities for people to collaborate. And this, I'm not talking about just South-North, North-South, South-South. I do believe that our collaboration should actually be diverse collaboration, but also making sure that for those of us who are already doing things, we should learn to pull other people. Let's mentor young people. Mentorship, we talk about mentorship and massive papers, research work, donor money into mentorship, but not really what makes a difference. To me, at the end of the day, we should do activities that make a difference. So I think I'll end there, and just to say that certainly I have addressed the 5 issues that I think still affect us. Food for debate, economy matters, human resources for health matters. It's not just about quantity or number of nurses or doctors, but also quality. And technology, a huge divide. And I think COVID-19 has exposed how weak our systems are. And of course, politics and culture. These are issues that need to be addressed, and wishing you all as you continue with the conference. And thank you very much to my colleagues. Been inspired even with what you've said. I hope I maintained 3 minutes, but if I went beyond 3 minutes, I'm sure you will forgive me. Thank you very much.
Thank you, Dr. Malata. I think I can say on behalf of everyone here that just from those few minutes with all 3 of our speakers, we've already received such excellent words. So we'll go ahead and dive into the Q&A panel. We will try to get through as many questions as possible, but we hope you understand that we will not be able to get through everything due to time constraints. First, we'll cover the questions asked on the registration forms, then move on to live questions. If you have any questions, please feel free to enter them in the Q&A box below. So we'll go ahead with the first pre-entered question.
Thank you, Khadija, and thank you again to all of our incredible speakers. So the first pre-entered question is just a general question. Is it possible to achieve the goal of decolonizing global health while we exist in a global society based on neocapitalism? If it is, how do we go about doing this? I guess anyone can start.
I guess I could take a first stab at this. I think that's a terrific question. I think foundationally, I wouldn't delink the two. You know, I think that the decolonization of global health would come hand in hand with also a foundational transformation in the political economies of and around global health that would be required fundamentally. I don't think you actually have a decolonized global health with the existing capitalist systems that we see today. And thus as a result, the decolonizing that we wish to see and think about would have to come about with a new framework for understanding foundationally political economy.
Okay, I can give a few more other questions as well. This is kind of along the same lines, but how can we go about decolonizing humanitarianism? Can
you say that one more time, decolonizing humanitarian?
Yes.
So separately from global health, I assume? It's a question. Yeah, I think that's interesting because I think there's a tendency for a lot of actors in this space to say, well, the need is so great in the humanitarian sector space, and there are, you know, it's urgent. We don't have time to almost, you know, take a step and be more inclusive and, you know, kind of do it the right way and adhere to these values. I think my argument would be that it's even more important to practice those values in a humanitarian space or setting. It was an argument that a number of us tried to make amidst the COVID pandemic or crisis, particularly because I understand why it happens, right? Because I think in times of urgency or crisis, people fall back on kind of business as usual. But there is a greater risk, I think, as we know from the data, of those most affected, those most marginalized, for lack of a better term, being left farther behind. And so ideally, what happens is we are building and sustaining these relationships over time so that if and when there's an urgent need, partners can come together who already have those relationships and ensure that there's adequate representation or diverse representation across the country or community in which they're working, so that we don't have these gaps in services and in you know, and who has a seat at the table, as Dr. Malata was saying. So that's hopefully that is getting to the question, but I think that there are, you know, I think that we can apply the same principles to humanitarian assistance or development, and in fact, be more sort of, not rigid, but enforce those more strongly in that space in spite of the emergency nature of that work.
Thank you so much, Loyce. If any of the speakers wanted to answer the questions, you should be able to unmute yourselves to pitch in.
Thank you, Khadija. With that, do any other speakers have anything to add for that question or the previous question?
I could add to the first question a little bit. I think it touches on the second, which is, you know, I think what's very important when we think about what an actual decolonized global health would look like, and I recognize that it's a process, not kind of, you don't start with a finished project and then move to that. I think decolonizing is fundamentally a practice that develops and builds on itself over time. We also, you know, have to recognize that the history of international health and global health is implicated and deeply connected to particular capitalist logics that then fundamentally drive health responses. And that's a challenge that we're seeing. I think it's being exposed very significantly by COVID-19, especially when we look at, for instance, the debates around the world on vaccine pricing and the potentiality of a COVID-19 vaccine and how much it will cost, and the fact that, you know, countries like Germany, France, and the United States and Britain are buying up the future vaccine supply at a significant level. If we can imagine a decolonized global health, wouldn't we imagine a global health future where access to a life-saving vaccine isn't necessarily measured or valued in terms of monetary and financial potential gain. And I think that this is an important moment to recognize how capitalist values link to valuation of necessary and life-saving products in medicine. And we really need to decenter that. And I think this is something that COVID-19 has really exposed even more starkly than perhaps before.
Thank you so much, Dr. White. We just wanted to let our attendees know that Ms. Loyce Pace can only be with us till the end of the hour. So we'll do our best to try to consolidate questions and make sure that questions that are even more specific to her and her work get asked in that time. So Ugo, I'll pass it off to you for the next question.
Okay, and the next question deals with language. I think, Ms. Pace, you also brought this up in your lecture as well. So this is related to that, but one participant had a question on what are the optimal ways to refer to countries and regions in terms of high and low resources, majority, minority, high, low, like marginalized, like not marginalized, etc. When there are other, what are the other related terms which we should be mindful of? So yeah, in other words, like, because you touched on this in your lecture, people are wondering, like, because we should avoid those words, like what else should we say?
Yeah, no, I mean, I fumbled too, right? You know, early in the morning in the States. And I think it's evolving. I think we have our own issue with this in the States too, in terms of how we refer to peoples or individuals who are affected like me. And my answer, honestly, hopefully it doesn't sound like a cop-out or too much of a deflection, but I don't think I am the right person to sort of answer that question or to communicate that. I mean, I talk about asking and listening. And so whether it's the person in the Q&A who promptly corrected me on my use of a term that I know that it's a habit we're trying to break, so that is not offensive to others. I think referring to people as people and places as places is the most fundamental thing we can do, and to be as specific as possible. And it's not even when we talk about civil society and communities, right? Are you talking about Ngozi? Are you talking about Kwanele? Are you talking about, like to whom are you truly referring when you're talking about engaging people, when you're talking about, when you're telling people's stories, which is an important part of the work that we do in the nonprofit sector. So that's, my commitment is to be as, specific as possible, as personal as possible, because not only are you being, I think arguably respectful, but you're, we know that none of us can speak for all of us, right? And so the less we clump, the more, sort of aligned we are and in honoring the stories we're trying to tell and the change we're trying to achieve. But I don't know if Dr. Malata has a take on this as well.
Yeah, I think you have. I think what you've responded is true, and I think I do agree with your thinking on this particular issue. But I think all we should always remember is that context matters, and I think it's very easy in global health to think everybody should do the same and do things in a similar manner. But we should always remember that our context really is different. And I think that realization would help us solve so many problems, although certainly, the power issue is always going to be there. But I do think that I just wanted to raise the issue of context. Context is different. Context matters. And I've gone to many international conferences, and even when people are discussing global health and all these issues, what is always missed is context. And I always raise my hand and say, whether it's WHO, whether it's at the UN, I'll say, where is context here? And I think that's something that we should always not forget. Yeah, thank you.
Thank you so much to our speakers. We have a live question. Someone's asking, in terms of rethinking development aid, Can you give or imagine examples of ways programs did it right by giving power over the use of funds to local people or government?
I'm happy to think about this question. I think it's something I even asked in my conversation with Kadi and Angela. One of the programs that I have in mind, in which they both work, is the Global Financing Facility. And it's something that's has been managed by the World Bank, and so it seems a bit counterintuitive that this would be something that would be a model. But the premise behind it, at least, is to allow countries to set their own priorities and be funded according to those strategic priorities. There's still, I think, some work to be done in terms of kind of this, I guess, sort of pay-to-play model. I think we can question the entire model of development and grant giving overall. But I think if we're working within this particular context, one of the things I appreciate about the Global Financing Facility model is that it starts with the countries, and that also is inclusive of civil society and communities. Again, not perfect, but it's something that I think some of the donors at a global level have tried to get behind in order to really foster more of a country-based, country-owned or led approach. One of the challenges is that that particular model, doesn't have the funding as sort of these bigger programs like Global Fund, Gavi, and others. And so some of these newer innovative approaches get dwarfed by those programs that have, 10 times the resources. And we can take that farther and point to all of the various country-based models that we don't even hear about because, again, they're not published in certain journals or they're not brought to certain international forums. But I know that there's work being done to further understand those innovations on the ground. But I think we're going to continue to run into this problem of how many resources these models have to work with, whether that's in terms of money or people. I can appreciate what Dr. White said about it not always coming down to money. And also I know that because of kind of where these pilots are happening sometimes or often they're overlooked because they're not seen as valuable by the way kind of this racist structure frankly measures that.
Thank you, Ms. Pace. Do any of our other speakers have anything else to add? If not, then we can move on to the next question. Do different political structures or systems of global health, so whether private sector versus public, warrant different approaches to decolonizing? If so, what are the differences?
That's a very complicated question, and a really interesting and very important one. Yeah, I think absolutely they do. I think there are a variety of different dynamics that we need to think about in relation to this. So much of the time when we talk about global health interventions, we often think about private entities traveling to countries or regions or locations and imposing a novel system that might detract resources from existing public actors or health systems that are working there, and subsequently undervaluing the work that's already being done. So there is in some ways an oppositional dynamic in that regard that I think needs to be taken into account. But also on the flip side, I think that even within areas that we may not think about as, or within countries that may need less or different approaches to decolonizing, let's say, especially post-colonial nations and areas, there's still decolonizing work to be done that I think, and this is where I think I get into the more theoretical and philosophical side of things, which is that, there is still a necessity to challenge colonial assumptions that have been held in place for far too long in the minds of those who are also historically have a relationship or an equal power relationship with colonization more formally. You can call it, as Steve Biko had called it, the colonized mind, but you can also call it a variety of other different things. And I think that there needs to be a recalibration of power dynamics in knowledge production. That's very critical, and that's very important. I saw in the chat someone mentioned, and Dr. Malata mentioned this as well, that there needs to be more translation into languages beyond just English and French and the colonial languages, which I think is a huge step towards that. And also on the other side, I realize this is getting away from the question, but I think it's germane to the topic. There needs to be a troubling of the assumption that global health actors can work in English and French and just get by around the world without engaging in understanding and listening to communities and countries that don't speak English or French.
Thank you, Dr. White. That was a complicated question, and I think you did a great job at answering. So I have a question that was pre-entered, and I think relates to a lot of grassroots and systems levels thinking. So it's, how can we make the colonialism influence more visible for healthcare personnel and policymakers? In other words, how do we sell the value of decolonization to leaders in our institutions when there's a clear power dynamic that we might not be able to walk away from?
Yeah, that's really tricky, right? Because it's so ingrained. Oh man, I thought that the last one was hard. This one I feel is harder. I think in terms of selling value, well, one of the things that strikes me is that you have a country like the US that even in the current political environment, the US still gives the most in this space. And that I don't say that to sort of expect any accolades for it. I think it's just something important to say out loud, because also at the same time that is true, there is a really big important question about the role the US is playing right now in the world. And that applies to sort of how that affects global health programs and those partners, or our partners in this space. And so what I've heard people asking is, well, what does it mean now that the US is sort of assuming a different posture in the world, one that's arguably more concerning or problematic than kind of where we have been historically, even though that previous model was imperfect or might have been imperfect. And I think that is serving as a motivator for governments, or at least citizens in those countries, to really question how much they want or should rely on that funding or that partnership or relationship. I saw a similar question about whether sort of the US or Americans should even bother if we're doing so poorly in this. And it's a question, again, that is actively being asked by people in this space who do the work. Because maybe the answer is to get out of the way entirely, right? But when I've asked that question, at least to the people with whom I've worked over the years, and even more recently, that hasn't been the answer either, right? It hasn't been, well, no, just go away completely. I think we can achieve success through solidarity, right? And we can accomplish something together that's mutually beneficial. I think there's obviously a lot that the US has to learn about our communities like those from which my family comes, or otherwise, and how we do business. And I think what we've been trying to say here at home is that we are at a loss as well if we don't continue to have those connections with people around the world. And so I think it's reframing the benefit as mutual. So that's one step. But then specifically, really thinking about it as any other kind of source of support or relationship. It's important to kind of have many people around us that can diversify our thinking and can make us, that much more rich in our perspectives and in our progress. And so that way, when one actor falls away or otherwise is kind of demanding things of us that we don't believe in or want to do, we have an option, right? And I think that's the important part, is that, countries, governments, leaders of these countries should always feel as though, that, like in the conversation I was having with Angela and Kadi, there's a sense of blackmail, right? Or there's a sense of just being so beholden to a country. And I think that in itself is, an argument for trying to find a way so that there isn't that, such a vice around the people with whom we work on the continent. I'd love to hear from Dr. Malata or Dr. Wright as well on that, and want to know if that's fair, or if the attendees think that's a fair response.
Yes, that's a very fair response. I think you are right. And I think you've raised some important issues here. I think I liked what you say about mutual benefit. And that's something that we always forget. I think usually the benefit is not mutual. Somewhere, somehow, there's an imbalance. And I think that's something that we need to be working upon. But what I wanted to say, I think when the question was posed, is the fact that I do think that we should also move beyond complaining, because it's always easier to really just push the negativity there. I've always believed that you should also take, these challenges sometimes as opportunities and see how best can we navigate through these issues. And I want to send the question back to the audience and to really say, look, you actually hold the future. You hold even today. And I think you can change the way things have been done. You have that power. Because the opportunities that you have today, even just sitting on this conference, is the opportunity I never had when I was at an age of 20, 25. No opportunities. I want to share maybe briefly to say that for me to get a PhD, it took me 10 years. And I didn't study in Malawi. I had to go to Australia for master's, for PhD. And such type of, challenges that one meets in life, they actually transform you to start asking those unusual questions. And I think the issue of grassroots is always something that should worry us, should make all of us feel uncomfortable, because at the end of the day, those who sit very high at the table probably don't even know what's happening here. So who can do it? You and me. And I think instead of saying like, who can do this, who can do that, my thinking is we should now start asking ourselves, what can we do to change the status quo? Thank you.
Thank you so much, Dr. Malata. That message of empowerment and positivity really rings through. Unfortunately, it's time for Ms. Pace to leave us, but we just wanted to take the time to thank her for her time and her knowledge with sharing her knowledge with us. I think we can all say that this is a difficult conversation, but we're all doing our best in our own work, in our own thoughts and discussions to try to address them. So we just wanted to thank her and allow her to say a few final words.
Well, thank you for that. I really have been trying to lean out and listen. So I hope I haven't been too quiet. It's sort of somewhat uncharacteristic for me, but I stand ready to continue to learn. Again, it's not common for a Black woman to hold this kind of position. And so I'm trying to do right by ensuring that I use any power or privilege I have for the greater good. And that includes really advancing some of the objectives of this conversation. And so I think let me know how I can do better. That door is always open. I'm incredibly grateful to have been included, and I think the organizers know how important it was for me to be able to lift up the voices of others like Kadi and Angela. So thank you for allowing them to be a part of this as well. And I apologize, the agenda shifted after I accepted, so I don't want people to feel as though I don't think it's an important conversation. I just had a prior commitment once things have been extended. So I wish everyone well today. You can obviously continue to engage with me or Global Health Council at any point in the future. The organizers know how to get in touch. We will be having a summit as well this fall where we will be trying to continue this conversation, particularly in a US policy context, which again, I think is critically important to make sure those people that hold a lot of that power really are challenging themselves or ourselves as well. So you all are welcome to be a part of that. But again, congrats to pulling this together, and I wish you well in your continued discussion. Thank you to Dr. White and Dr. Malata as well.
Thank you.
Thank you very much. It was a pleasure sitting with you on this panel. Thank you for your insights.
Thanks so much.
Thank you.
All right. We have a follow-up question to kind of addressing this inherent power dynamic in global health. Talking about, who is financing global health, right? So we know it's a few people. There's the Gates, Clintons, who make decisions for all of us in the rest of the world. And this attendee says it's going to be very difficult to change this discussion. So how do we move from there? How do we move from such huge power structures and the powerful few making decisions for all of us?
I think I can start responding. So I still believe that there's an opportunity to change things. And I think the issue I raised about, can you sit on that table and can you make decisions? And I'll give you an example. A few years ago, Melinda Gates came to Malawi, and she was meeting our head of state. And so the head of state, who was also female, invited me to sit with her during the visit. And it was quite interesting that our head of state, former head of state, Joyce Banda, was able to push questions to us. So we had a direct a conversation with Melinda Gates about the need for support for maternal and newborn healthcare in Malawi. What lessons did I learn? The lessons I learned was, yes, you may not have the resources, but I think ability to passionately talk about what you think your people need and what can be done can still make a difference. Because, at the end of the day, yes, there are a few very, top individuals that have got the resources, but they still have to spend those resources. I think for me to start saying, how can we get as many people have resources, probably is a very difficult question. To me, what's important is, at the end of the day, what's happening to those resources. And I think I don't sit here complaining that we have few individuals that have got resources and big donors. To me, is how do those resources trickle down to the person in the rural area, grassroots, who will not sit in State House, who will not be in a conference in New York, who will not be in a conference in Johannesburg. They are in their rural village in Zimbabwe, in Zambia, in Namibia, in Asia, somewhere in India, and in rural Pakistan. So for me, the question should be, for those of us who now sit to receive, can we get these resources down there? And to me, I think that's where the problem is, that perhaps resources come in and they don't get to the grassroots. And I don't worry so much that perhaps there are few individuals who have got resources. For me, are these individuals giving the resources, and then the resources are getting down to the person, that rural person who has no voice, who never travel? To me, I think that's the question, because at the end of the day, we can't solve all problems. And I think in global health, there's that challenge that there's so overwhelming issues, many issues that come to us, and we all think like, how can we do this? How can we do that? To me, at the end of the day, is in your role, wherever you are, whether you're a student, you're a medical doctor, you are a nurse, sitting somewhere, maybe you are in charge of a facility somewhere, because most of you are students, one day you find yourselves in different positions. What difference are you making when those resources are there with you? Because otherwise it's very difficult to see how we can widen the resource base of these specific individuals. But I don't know what my colleague thinks. But as you remember, I'm talking from different contexts. I'm in a low-income country, so I'm always thinking that way because I know that we really can't solve our problems. Thank you.
Yeah, I'm in full agreement with all of that. And I think, you know, I want to think about also the fact that, you know, the decolonizing global health also means we have to decolonize entities like the Gates Foundation foundationally. And I think, and this is a call to many of the students who are on this chat today, which is, you know, if you are looking at working at one of the major global health entities like the Gates Foundation, you know, it's your responsibility also to decolonize those spaces. And I think that means very significantly that, you know, it's about also the ways in which agencies like the Gates Foundation approach the challenges of global health and whether or not those can be decolonized. An example would be, for instance, you know, malaria control and eradication since the World Health Organization first started actively focusing on malaria eradication has always been a vertical approach to a health problem that is not just about a mosquito-borne vector disease, but is actually about a host of other social, political, and economic considerations that affect the spread of malaria. So there are ways in which we can think about not necessarily targeting specific diseases potentially, as that might be a only challenging part of the problem, but actually broadening our approaches to think about the ways in which a decolonized global health approach treats more than just a single disease or a single issue, but attempts to ameliorate other areas that of social ill and healthcare that are that take seriously local contexts and also the needs of people in a space, as opposed to simply treating the symptoms of a wider problem or wider set of problems. So it's about decolonizing both it's about fundamentally decolonizing, I think, those agencies as well and those institutions. Yeah, absolutely.
Thank you so much, Dr. White and Dr. Malata, for your very nice words. And I think in the space of, you know, what we can do in our own practice to decolonize global health, this goes back to the language of language, really. You know, when we talk about low resource, high resource, low middle income, high middle income, there's a question about how we name and frame. I know Dr. Ms. Pace actually answered this question a little bit, but how do we move beyond the idea of the term beneficiaries, right? I know she mentioned we, you know, speak to countries specifically. We mentioned their names, but there are other languages that are used in global health, and I guess this attendee wants to know, what can we use instead? So if anyone has any inputs on that.
Can you come again?
Sorry, Dr. Malata, did you say something?
So just asking that if you could repeat the question, please.
Yes, the question is asking about naming and framing. How do we refer to people in communities that are engaged in programs? How do we move beyond like the idea in terms of words like beneficiaries, for example? What can we use instead?
So I think this is kind of in some ways a linguistic question that I think is actually very important, because it's a linguistic question with deep historical roots to it. You know, I think when we think about designations like developed or developing world, we have to refocus that binary within the context of a history of colonialism. And the fact of the matter is that, you know, the countries that we consider to be developed, quote unquote, are so because of the extractive practices that foundationally underdeveloped the world that they relied on for resources and controlled through violence, coercion, and political and economic power. So when we think about beneficiaries, or when we think of developed and undeveloped, we also have to recognize that those words exist in a relationship and in a power dynamic that also needs to be foundationally challenged. And this is a really important point, because I think it decenters the conversation from thinking about the health systems in the in the West, let's say, or pick whatever term you want, or the health systems in the overdeveloped West as being totally separate from the activities and health systems and health situations in the rest of the world. And I think that the ways in which especially Western Europe and North America has disengaged itself from a relationship to the negative outcomes that we see in much of the rest of the world is something that we need to reckon with foundationally, so that we don't think about necessarily beneficiary countries, but actually think about potentially reparations foundationally for colonial harm, or challenge the implicit power dynamics in that sort of language in a variety of different ways. And that comes with a confrontation with history and a confrontation with the ways in which I think the more powerful economic nations have wiped their hands of their complicity in creating the problems that existed elsewhere.
Thank you for those responses. We do have another question specifically about research. And one question someone posed was, if local research has to be read, recognized, and used, it has to be translated. So an issue that a lot of research has in global settings is that it's published in English. So what solutions can we think of to remedy this problem, if there are any?
So I'll start. My thinking has been, I think, as I said earlier on, is let's go beyond English. But then when I say let's go beyond English, it means we need to have experts in the other languages all over the world that can actually process high-level, high-impact journals. Because it's also not just about publications or just putting up anything for people to read. And I think that's why I like your conference, because with the diversity of membership, if we build capacity in different parts of the world and with people who have knowledge of different languages, it is possible to start, pulling on the part of publications and making sure that we have. I'm looking forward to a time we'll have publications in, is it Swahili? I don't know how it's actually. I think they keep changing now the wording. But what I want to say is, like in Malawi, we speak Chichewa. If there were 3 other countries in sub-Saharan Africa speaking my language, I would want to see as many publications. But at the end of the day, remember, you want to change policy. It's not just about writing. It's not just for academic purposes. You want to make sure that your message from that research goes out to the people that, maybe look at resources. So you want the World Bank to read. So my thinking is that you really have to look through all the bottlenecks. And then there should be a day at World Bank where you can have somebody that can be looking at, publications in a different language beyond the common languages, the WHO languages that we look at in global health. So in other words, what I'm saying, that this is a process. It might take a long time, but I think it's one way of making sure that we address the issue of language. It's very important. I do believe that if you look at the tiger countries, they've basically been using their languages. Today you go all over the world, you find that some of the languages that people are using, even in secondary education, primary education, is not their own language, because they're trying to achieve their agenda. So I don't want to mention countries here, but it's doable, and we are seeing some changes already, but we should strive. So in your own country, wherever you are in the world, one day you should be an editor and be able to look at that research work and publish it. And I mean, even if it means translating again into another language for other use, I would think that that's still okay. Thank you.
This is a similar question, or related question rather. Dr. Malata, you previously mentioned that imbalances exist in research in terms of like who does the research and who benefits from the research. So how can we ensure that when the research is done, people in a specific country, like where the research is being conducted, benefit from the data gathered or the research performed? Like, should there be some sort of research ethics protocol that is followed in global health? And should this be mandatory?
I think it should be mandatory. Let's start changing the policies and then to say, if you're, so I want to give a live example of what I've seen. So I've gone to international conferences and I'll be sitting in an audience and somebody's talking about my country. And I have no idea where this was done. And sometimes you look at ethics, whether things were done in a proper manner. So what I've decided to do now is to start questioning. So if I hear you in Canada, you're presenting a paper on Malawi, and I seem to doubt that there was true involvement of people in my country now, even whether it's ethics approval and whether there's a Malawian on that paper, I'll raise my hand and question that. And I think we need to start doing that. You know, you go to conferences, you are sitting in that meeting, no representation from a country, and people are talking about Kenya. And there's no one from Kenya who can present. So for me, for now, like if people come into my country and they're doing things and they have control over that, I'm always questioning, where is the Malawian on this research team? And so I don't approve any research now in my university if the research doesn't show that we have leadership. And I don't want us to be appearing at the very end of that paper, even if it's a publication. Yes, sometimes you haven't done much, but certainly they shouldn't be talking about countries when the owners of those countries are actually at the end of that paper. If they ask you to participate in paper writing, ask them, where am I going to be? So if you are the last one, just know that they're saying you didn't do much on that paper. Yes, collaboration is important, but I do think that we should now start questioning issues, and we need to prepare our leaders. So I'm not a politician, but I think I can give guidance to my Minister of Health, Minister of Education to say, look, this will not benefit Malawians. This is about someone trying to become a professor, or they want to raise their profile. And I think I'm looking for such type of young people in globally who should be able to step up and say, no, this we cannot take. Enough is enough. And I do know there's a power issue about resources, and sometimes people withdraw, and I've lost resources sometimes when I've raised those questions, and next time your name doesn't even appear because you raised the question. And because I've done work in my country, in Africa, and globally, I know what I'm talking about. It's not that easy. And because you don't have that financial muscle, sometimes if you raise such questions, you'll notice next time they don't invite you. And I think I've reached a point where I don't really care if they don't get me back on that panel, or they don't get me back on that team, because I've raised a question. We need to start asking uncomfortable questions, but not just for the sake of asking, but for us, it should be about, is this going to benefit the grassroots, or is people just trying to make a name? But thank you. I'm sure my colleague would want to respond to that as well.
No, I think you answered that perfectly. I don't want to follow up on that. I don't have anything to add. That's brilliant.
Thank you so much, Dr. Malata. We have a follow-up question that kind of resonates with what you just said, asking, how do we bring diverse women to the table to voice up and change policies when we don't even get a chance? What avenues are available right now? I think you touched on this a little bit with mentorship, but I think you can further address the question.
Yeah, so that's a very good question. I think for me, let's build capacity. So capacity building is very important, because remember, you cannot argue on an issue that you don't know about. So for example, for capacity building, for me, I advocate for women to really go to school, and I share my life story, how I navigated through education to do my diploma, the degree, and then a master's and PhD. The reason why I decided to go that far, and in Malawi, in my time, I was like the third person to have a PhD. I had to go to Australia, I had to go with a baby on the breast. I was doing it because I saw in my country that you cannot make you can't be, listened to if you don't have the qualification. So it's not just about women, because so many times women feel, oh, women in global health, and I'm now chairing a chapter in Malawi. People think somebody should be feeling sorry for you. No, you have to earn that position. I'm vice chancellor. In my country, I was the first woman to be a vice chancellor. Now I can talk about it, but it would be sad if I'll be the last woman to be a public university vice chancellor. I don't want that. So what I do is make sure that I should start building capacity of other women. And we should not be blaming men. Now I'm talking to women here. Women should pull other women and make sure that you build capacity. So if I do research, if somebody from Johns Hopkins want to partner with me, they should have confidence that I'll be able to do the right things here. So that's the capacity building I'm talking about, the qualification you need, experience in research. So there will be times, yes, you'll be perhaps a co-investigator, or maybe even just being hired to collect data. It's okay, it's a process. But you should develop yourself to a point where, yes, initially you're just collecting data, but at a certain point you're a co-investigator. And then another time you are a principal investigator. And I think demanding that you get that PI position is very important, because then when your data is being used, or you have to use data with colleagues from other countries, you have the power. Because you don't want just to be on a paper as first author when you didn't do anything. So let's build capacity. And I think it requires resilience. For countries where resources are very few, when I got my scholarship for PhD, the baby was on the breast, 10 months old, another one 2 years old. I had to take my baby with me. My good husband kept the other baby here. And when 3 years, I was back with my PhD and was able now to take leadership and in the healthcare system in Malawi and the educational system in Malawi. When you were talking about my profile, I had to do it because at the time there were very few people. But I made up my mind, the time I leave the nursing profession in Malawi, I should build massive capacity. So in my university, when I was joining and taking leadership as principal of the College of Nursing, 3 PhDs. And 8 years later, after my leadership, I'm leaving the College of Nursing, 40 PhDs, very powerful faculty. And I left without even complaining, because I knew my colleagues would now carry on the work. And then now we're into PhDs, and so you don't have to go outside. The reason why I did this is for me to develop, to build that capacity, I had to go out of Malawi many times. So go for master's, go for PhD. And I said when I came back that I need to do this in my country. So not every woman has to leave Malawi. They can actually study here. And then I want to go back to the issue of mentorship. There are many women in global health that will say, I'm the first woman to do this, I'm the first woman. Well, it's good. We can talk about that. We are first in this, I was first woman this, but it would be sad then if you're first and the last one. Your aim should always be, can I pull other women? Now, also remember that our male counterparts can be very good allies. And I must say, be honest here, that I think colleagues that have really pushed me to be where I am have been, male counterparts. So don't always be afraid of men, because it's in women, in global health now, it's like, men are enemies. They are not. Not always. There will be some men that may pull you, but certainly maybe sometimes it's fellow women that will challenge you. But I must say that there are male counterparts that are willing to see so many women grow. And for low and medium income countries, my cry has been, we don't have enough people, enough women that can take that leadership position. I have ended up, if I tell you that many issues over the last 20 years, always being invited to this panel, invited to this research group, because when they are looking at Southern Africa, Sub-Saharan Africa, or looking at Africa even, there are times I've been told, we're looking through, your profile, I think you can fit into this. I've always felt very sad that I really want to see as many women. So there should be a time when they can choose from 10 of us. But very few women are willing to take up that challenge. It requires resilience, it requires focus. Don't be everywhere. Focus. If you're maternal health, go maternal health. And yes, you can collaborate with other people, but just follow through your entity. And also you should be able to say no if you can't do things. Because there are people who accept to do things and then they are not able to fulfill, then they are dropped next time. But be a star performer. And I think for me, if you are hardworking, you're focused, you can actually achieve more. But let's build capacity for low and medium income countries, truthful capacity. And many times, if you look at our colleagues in high income countries, they have one strength. Majority of them are hardworking and they are determined. When they want to do something, they will do it with all passion. For us, quite a number of people, and I've always complained, I mean, when I talk to my own students, when I'm teaching, I say to them, look here, hard work pays. And when you go to that conference, say something. You go to a conference, you keep quiet, all you do is break time, you rush in for tea. No, say something in that meeting. I learned that when I was young. So if I'm invited to any meeting in the world today, whether they're heads of state or not, I raise my hand and I always say, I'm I'm coming from Malawi. And many times during tea break, people coming to me, are you the lady from Malawi? What you said was very powerful. And then I end up, getting, opportunities because people say, okay, she was able to say something. So I tell my students, if you cannot ask a question, just say to the speaker, well done, that was very powerful. You've raised very important points and I think we need to think about this. I think once you say that, people know that you're listening and that's what we need to do. So I can lecture on this for a long time, but I know my colleague would want to comment and I want to hear your perspective on this particular matter. But let's build capacity, let's mentor other people, but the people themselves, the young people themselves should be willing to take up these positions and not be fearful. And as I said, once again, say something when you're on that table. It's very important. People will not guess what you're thinking about because most of you are very intelligent and have got potential. Thank you.
Yeah, I totally agree, and it's hard to follow that up. I want my comments on this come from the ways in which I think I see myself as an academic, and that's not necessarily as a practitioner, and how I think there are a variety of different ways to create or to challenge the ways in which women have historically been left out of these conversations in global health. And I think one of the fundamental ones is structural, which is that far too often we segregate women's health as, oh, these are women's problems in global health to be dealt with separate from some perceived universal global health problem, which is just basically just coded language to say that men's health problems. And foundationally, there are no health problems affecting women that don't have significant effects on absolutely everyone. And women's health, and I think that it's a sexist and entirely deeply flawed intellectual approach to suggest that any health problems that can be relegated to supposedly the domain of women should not be at the forefront of all global health conversations. And not only is it morally and from a value standpoint inaccurate, we also know it's inaccurate from a variety of empirical foundations. So I think when it comes to education in global health, and which then leads to people going in and becoming practitioners, I think we have to decenter who our who the subject of global health foundationally is, or who the subject of interventions are. And we need to challenge the fact that referent is so often just a faceless man somewhere and not foundationally a woman or literally anyone else. And I think that if we can decenter our conversations and focus on women, but also focus on women primarily as the starting point for thinking about health activities healthcare and health interventions will actually not only normalize and justify and provide far more spaces for recognizing the importance of women in global health, not only as practitioners but also as those who need healthcare support. I think it broadens the conversation and hopefully nullifies our inherent sexism in the field. I think that this is very important.
Thank you so much, Dr. White and Dr. Malata. Those are very, very interesting questions, and I think our audience has, responded to, these topics, asking questions. I'm going to summarize here just because we have a few questions about it. Dr. Malata, specifically, when you talked about, being on the team and being resilient and asking those difficult and uncomfortable questions, and it's basically wanting to know specifically, what did you do to build capacity? What did you do when you weren't not invited back to speak at that, that conference where you spoke up and asked the questions? How do you keep the door open for, other leaders from your country to follow, when it is that you do retire? So questions around that theme, if you can, offer us insight into, specific initiatives that you champion to make sure those things are accomplished.
Yeah, so it's a mouthful, but I think to me is I think just being open and the fact that as you go through life experience is your own example, is your own good teacher. So even if when you're not invited, you keep your focus, you keep doing what you're doing, and not feeling disappointed if people don't treat you properly. Over time, people start realizing that perhaps you can add value. And to me, as at the end of the day, I'm really always very mindful of, at the end of the day, when everything is said and done, what would I have done to help those that don't have a voice? And I keep talking about that because that's common in my context. And as I said earlier on, building capacity for me has been, so wherever I am, whatever position I get, whether it's on the board, whether it's a job, I was always want to make sure that I build that capacity, not only for women, but also for even other men, calling people to serve with me on the board. If I'm leaving a board, I want to make sure that somebody who is coming in is my mentee. And I sit with them and I keep quiet. I've learned to keep quiet and give them an opportunity to speak as well, because mentorship is not just about informing people, oh, this is what you need to do. It's also ability to take them out, give them an opportunity. So I sit on Action Aid board in Malawi. I'm chairperson. I'm mentoring another lady. And what I've said to her is the last 2 years, all international trips she should take. And then she goes there and I want a report back and I guide her. This is what you do. This is how you're going to do things. It's very common in my context, people to think every opportunity. Now COVID-19 has made people stay home and do things virtually. But before COVID-19, everybody's everywhere in the world, particularly even in global health, conferences, meetings. Let other people do it. And I think the ability to say, I've done enough. And I think when I share about my life story, I'm always talking about, if you look at the years I spent in the College of Nursing with 30 years, 10 of those in leadership, I reached a point after I built capacity of faculty that I realized I needed to give space. Giving space to other people to develop is very important. When you're very well known in your field, everybody calls upon your name. Think about this, Professor Malata. Health workforce, Professor Malata. Nursing, Professor Malata. Maternal and newborn healthcare, sexual and reproductive health. So what I realized is that sometimes you need to step aside. So I left the College of Nursing about 4 years ago, when one day I got out of my office and the 3 people I met all had a PhD. And I said to myself, if I can get out of my office and within 3 minutes I meet all these PhD holders, 40 of them, if I keep staying in this institution, they will not grow. So when another job opportunity came, I applied and left. And I left in style because they didn't even know I'd left until there was an announcement, the woman is now a vice chancellor for the first time, but I had left the college and I didn't even go for a farewell. And they said to me, we need to give you a gift. Why? Learn to give space. Give space to other people. So if you don't give them space and you're saying you're mentoring, you will not actually achieve more. So I think it's always important to give space, live for other people. And when you've served on that board, learn to do things to a certain point, and the ability to say, I think I have served, can someone take over? Many people don't do that. They want to do it until they drop. And then they say, okay, somebody can take over. Sometimes they're already not speaking. But I do think that let's give space, ability to say, I have done this, let other people come on board. And I've done that, and I think that's how I'm trying to create my legacy. Let other people do it, let them shine. And when you go to that conference, you've been speaking enough, learn to keep quiet. Allow other people to speak and listen. For me, the reason I say put up your hand is because many young people have challenges stepping out to speak, particularly in a society or in an environment where they are not known, because they feel they'll make a mistake. And I also want to say it's okay to fail, because I think as you try to go through the trajectory of growth in global health, there are times when mistakes happen, and it's also good to acknowledge that this was a mistake and you want to move on. That's okay too. Ability to say also no. These are life experiences for me, because many times we just say yes, and because somebody has got resources, oh yes, it can be done. You should be able to say this money will not come into my country because I do think it will not benefit the people of my country. If you get to a position where you can make that decision, not just receiving because you don't have the financial power. And these are tough decisions that we all have to learn to make if we're going to make a difference in our countries. I think I'll stop there. Thank you.
Thank you, Dr. Malata. We have another question about specifically about curriculums. What types of changes would you both like to see in how we train future global health leaders and professionals in the workforce? And what topics should be added or emphasized within curriculums?
Sure. I mean, I think that the first thing that I do when I teach a public health course, especially around infectious disease control, is that I try to provide the historical context for the histories of infectious disease control, especially outside of the United States. And this often requires, or always requires an intervention in thinking about the dynamics of colonial medicine and health that have been inherently structured by power dynamics that are reproduced in the present. And I think what this does is it gives many students an understanding of or a new understanding of how to approach global health, recognizing that international health and global health didn't just emerge out of the post-World War II era with the creation of the World Health Organization and the World Bank and others, but rather there's a longer history into what Randall Packard calls the interventions into the lives of other peoples. And I think that's a really important framing because it fundamentally reconsiders how we should address and think about the practice of global health, the power dynamics implicit within global health, and opens up a host of new conversations. Another thing that I do, especially in undergraduate courses, especially when I teach about race, racism, and medicine, is what I mentioned earlier, which is begin the class by focusing upon dynamics of oppression and medical violence that have primarily been visited upon, in this case, in the class that I'll be teaching, Black women in the United States through history, focusing on or challenging the assumed referent body of a male body in health, and seeing the ways in which that foundationally shifts our conversations to open up a wide variety of engagements that I think would not be there if we just comfortably rested on our existing gendered sexual assumptions that I think we would go into the start of class without that sort of shift in perspective.
And I think in addition to, for me, I also believe that what we can do, the advantage with the curriculum is that you are in charge of that curriculum. So in your own context, so it's very easy for you to say, I think let's add these topics. And I think for me to specifically say we would add this topic perhaps maybe going too far, my thinking is that when you have that curriculum, you know what that curriculum should be addressing. So like for me, I can see what other curriculum documents look like on global health from all over the world. And I like doing that when I'm developing a curriculum for my own country, or I've been asked to develop for another country. But at the end of the day, I always want to say, okay, so how does this fit into this setting, into this region, whether it's Africa or Asia? How does this fit into here? And then therefore, when you're putting up that document, even in terms of modules, or topics, units, you make sure that it is actually localized and you give local examples. So you will not be giving an example about New York when you are actually somewhere in Nairobi. The example should be from Nairobi. What does this mean in Nairobi? And I think that's something that we need to do. My background actually is education. So curriculum documents is something that I've done over the many years, and it's very easy to localize, and we have to learn to localize. And I think many times people are just borrowing documents and forgetting that London would not be, like Perth in Australia. So we should always, localize information. And then even as you develop topics, your topics should actually be linked to the content of your curriculum. And I think has already been discussed, I think we have that power to change. I don't think anybody will blame you, as long as your quality issues are maintained in that curriculum. And for somebody who has done education, for a good curriculum, you know what is required, what are the basic minimum standards for that curriculum. You need to meet that, because you also want to make sure that that curriculum, if somebody comes from any part of the world, pursues that program, they should not be questioned. To say, no, this global health, because it was done in Rwanda, it's not good enough. No. Your global health program in Rwanda should be as good as the one that somebody is pursuing in Switzerland. And that's the type of standard. So I know that in most low and medium income countries, people think that no, the quality should be that low. I don't believe in that. I believe the quality should be as good. Yes, resources may not be there. We don't have everything that we need, but we can still maintain, because what is important for quality in education is meeting that minimum standard. And you have that power. The person who is developing that curriculum has got power to localize and I think make sure that we meet what we're discussing here. Thank you very much.
Can I just add?
Yeah, sure, please.
If I can just add to that. I think, and this is speaking especially to students in the United States and Europe. I think that often when we're taught about global health and we're taught about the social drivers or the underlying drivers of things like non-communicable diseases, we so often take as our reference site studies that emerged in, for instance, the Framingham Heart Study that took place in Massachusetts in the mid-20th century, focusing on a very, very undiverse population. And then we attempt to apply the risk factors around heart disease and certain cancers to the rest of the world. And I think what we need to do is fundamentally challenge, as Dr. Malata said, we need to focus on specificity and challenge which geographies become the referent for exporting health policy worldwide, because foundationally what's going on in Framingham, Massachusetts in the 1970s is very different from what's going on in Monrovia, Liberia, or a host of other places around the world. And teaching people to recognize and confound these assumptions, I think, is the first step in many ways towards careers that foundationally do that in all areas.
Great words, Dr. White. Thank you so much, Dr. Malata and Dr. White. I believe we're out of time for a Q&A panel. We thank you so much to our attendees for all your amazing questions. We hope you're able to get more, clarity and knowledge on these topics. And hopefully we will be able to, discuss more in the workshop groups that are upcoming. A special thank you to our expert panelists, Drs. White, Dr. Malata, and Ms. Loyce Pace. We're so incredibly grateful for the time that you have devoted to pre-recording lectures and also speaking with us today, especially considering your very busy schedules. So we just wanted to express that gratitude, and you can say a few final words to the audience.
Thank you very much. It was an honor to be part of this, and sorry that I was working under pressure the past few weeks, but I do hope that just being available today was also good enough to know that there are people listening, and I'm available in case people want to send questions to me. I think you can share my email or my contact, but otherwise I wish you all the best and keep up the good work. Thank you.
Thank you so much. It was a real honor and a pleasure to be here. And thank you so much for all the questions. Thank you for organizing this. This is fantastic. And also, please, if anyone has any questions, feel free to email me at my Johns Hopkins email. So thank you so much, and have a great rest of the day.
Thank you so much. We appreciate all of you. All right, so we'll start to transition to our breakout rooms.
Okay, I hope you all can see my screen here with the remaining schedule. Before we take a 15-minute break, I wanted to share some information about the next phase of the conference, which will be an hour-long workshop. Everyone who has opted to participate in a workshop will have the opportunity to discuss decolonizing global health from the perspective of one of 4 different topic areas: education, research, health systems, or health financing. If you are participating in the workshops, you should have received a separate email with information about how to join the Zoom meeting for your assigned workshop. At the end of the break, log on to your specific Zoom link directly. If you are having trouble or can't find the link, please email dghc.jhu@gmail.com during the break. After the workshop sessions, we will all rejoin this webinar link at 4:20 p.m. GMT to hear what the different workshop groups discussed and to listen to our closing speaker, Dr. Triyono Sondoro. That's all for me. Please take your break and enjoy your workshop discussions.